the pediatric ARDS consensus recommendations, and a lot of you who attended the Brightside Symposium, this might just be a repetition, but I think going through these guidelines, it's never it doesn't harm to go through them again and just revise them. So again, these are the recommendations as Todd mentioned. The who's who in pediatric critical care came together and practiced. So again, the importance of this is, this is more just knowing how our practice is and just comparing it to our peers across the country. So what is ARDS? So what does when you use that term, what does that tell you? That's true, but what does it mean? What's happening?
Your kids' lungs are leaky, and you're not oxygenating well, changing gas as well.
Yeah, absolutely. So I mean, one of the most important things that they're looking at is the oxygenation, and so it's just impaired gas exchange. So basically, it's lung injury that's happening, and due to whatever reason, and then we'll come into the causes of ARDS later. So the way you look at etiologies is something that affected the lung directly, and something that is happening in the body will affect the lungs. So that's indirect. So the direct ones are these, and there's a long list, and it's again not. There's much more to this than what the list is. And so bronchiolitis, we talked about, pneumonias, viruses, bacteria, aspiration of gastric contents. So aspiration, pneumonia, drowning or submersion can cause ARDS. Trolley, does anyone know what trolley is? Yep. So transfusion-associated acute lung injury can happen. Yeah, transfusion. Yep. So a lot of kids, if they're getting transfused, and if they have like a respiratory reaction, that's usually trolley. That happens usually in 2 to 4 hours with the transfusion. Post-obstructive pulmonary edema. So that's from negative pressure, inhalational injury. So burns, pulmonary hemorrhage, and pulmonary fibrosis. The indirect ones. Can anyone give me some examples of indirect causes of ARDS? Mm-hmm. Absolutely, pancreatitis.
Just overwhelming sepsis.
Sepsis, absolutely, that's a very important one, yeah. Yep. So yeah, absolutely, sepsis, pancreatitis, I think those are the two most common ones. Fat embolism, so if you have a long bone fracture, a massive blood transfusion can do it. Major trauma can cause ARDS, anaphylaxis, and again, if they're post-lung transplant or post-stem cell transplant. But sepsis and pancreatitis are two of the most common indirect reasons for ARDS. So what's the pathophysiology? And again, just one slide about that. We don't have to really go into detail. One is the initial is the exudative. So you have a lot of exudate inflammatory markers coming in. You have a lot of cell proliferation and then causing fibrosis later. So you have alveolar inflammation. They have depletion of surfactants. So if you remember, you have a type 1 and type 2 pneumocytes. The type 2 pneumocytes are the ones that produce surfactants. So they get affected. They have a lot of capillary leak that happens. So you have just a spillover of the extracellular fluid. You have alveolar collapse, which causes an increase in physiologic dead space. So what do you understand by dead space? Rachel, what do you think? What is dead space?
Or like COPD.
If it's not participating in any gas exchange.
Absolutely, yeah. So the part of the airway that doesn't participate in gas exchange is dead space. So we always have some amount of dead space, right? Our upper airway, our trachea, major bronchi, we do not have any epithelium to have any gas exchange. So there's always a fixed amount of dead space that we have. That's the anatomic dead space. And then the physiologic dead space is the alveoli that are getting collapsed because of inflammation or bronchiolitis, pneumonia, and they were initially participating in gas exchange, they are not participating, and that's the physiologic dead space, and that can change. Usually the physiologic dead space in a healthy lung is minimal, but that increases with disease. And then you have poor oxygen transport, and this again is just a pictographic representation. So this is a normal alveolus and how it can get injured in ARDS. So just looking at just a brief history, we don't have to go through these slides in detail. So it was in 1967 there was the first description of this, and this was based on 12 patients with tachypnea, poor lung compliance, hypoxic failure. None of them were. I think there was like one kid in these 12 patients. So the rest of them are all adults, and they said the changes were similar to neonatal respiratory distress syndrome, which is from surfactant deficiency and prematurity, and that's the reason they called it the adult RDS, and that's where that term came from. And then they met again in 1994, and they said, well, you have to include kids as well. So that's why they said it's acute RDS and not adult. So plus they give some criteria. It's just again, the reason why these criteria are used is so that the entire world speaks the same language. So when you say ARDS and when I say ARDS, we have to mean the same thing. So they said it should be acute in onset. They should have severe hypoxemia. So you look at your PaO2 divided by FiO2 ratio, and if that's less than 200, you need to have bilateral opacities on X-ray. And you should have an absence of left ventricular failure, which is confirmed by clinical exam, or you do a cardiac catheterization, and you look at your wedge pressure. That's the way they diagnosed LV failure. And then came the Berlin definition. So the reason why the Berlin definition came is because the initial one, it said just says acute. It doesn't say what is acute, like less than 10 days, less than 20 days. So it said within a week. So there was a timing. And then they said imaging-wise, they have to be bilateral opacities that are not fully explained by fusion, collapse, or nodules. And then origin of edema. And then ARDS was originally called as a non-cardiogenic pulmonary edema. That was the old term. So when you have edema that's not explained by either heart failure or fluid overload, then that's ARDS. And they said not everyone needs a CAT, because these kids are sick enough, you're not gonna, even adults are sick enough to do a cardiac CAT, so an echo should be enough. And then they came up with these criteria, the mild, moderate, severe for PF ratios. And they said these patients need to be on at least a positive pressure, a PEEP or a CPAP of 5 and more. So someone's on high flow nasal cannula doesn't qualify ARDS. Someone's on breathing room air but has bad lungs doesn't qualify ARDS. So they need to have at least a positive pressure of 5 and above, plus this to say they have ARDS. So, but again, why did we need a pediatric definition? So again, it did not take kids into consideration. There was all they wanted is a PaO2. So when you say PaO2, that means every patient needs an arterial line, and as you guys know, getting an arterial line in every patient is not always possible, especially if they're not intubated. So you're missing kids who only have a pulse oximeter reading. You need a PEEP of 5, but again, they talked about just invasive. They didn't say about non-invasive. We do use a lot of non-invasive ventilation. So how do you classify those kids? They did not look at outcomes. So, okay, like what is going to happen if you say mild ARDS versus moderate versus severe? And then as we talk about, there's always going to be these differences in the risk factors, the pathophysiology, etiology for kids. We see this all the time. Kids are not, miniature adults, so there had to be a specific pediatric definition. So these are a bunch of societies that came together, and they met at this Pediatric Acute Lung Injury Consensus Conference, and they came up with these recommendations. PALISI is our North American one, so that's the Pediatric Acute Lung Injury and Sepsis Investigators, and then these were across the world that came together. So their goals were that they wanted a proper definition, so specifically about predisposing factors, etiology, pathophysiology. They wanted to offer recommendations how to support these kids, and then identify priorities for future research. Again, looking at short and long-term outcomes. So what were the key differences from Berlin definition? And I've just put them in bold type. So according to the pediatric definition, we do not require bilateral lung infiltrates, as Todd mentioned. Even if you have unilateral lung infiltrate, that's okay to call ARDS. Again, introducing the use of pulse oximetry. So you can do an SF ratio instead of a PF ratio when you don't have an arterial line for the PaO2. And then using oxygenation index or oxygen saturation index. So when you have a PaO2, you use oxygenation index. When you have just a pulse ox, you use oxygenation saturation index. Again, with a minimum PEEP. And then looking at criteria for kids who have chronic lung disease, because this is a big section of population that we treat, right, with the ex-preemies, and then kids with cyanotic heart disease. So if they get ARDS, how do you define them? And then identify kids who are at risk of getting PARDS or pediatric ARDS. So this is the, and we can put this in a laminated sheet. We can have it for our PICU and PEDS. So this is looking at stratification as to what is mild, moderate, severe. As far as kids who are, once they took away the PF ratios here, and that's only, they're using PF ratios only for someone on like a CPAP or BiPAP. The reason is, that for example, like we talked about, if you have a patient on oscillator who's on a mean airway pressure of 30 and whose OI is, whose PF ratio is, great, because if their PaO2 is 100 and if they're on 40% oxygen compared to who's on a conventional ventilator with a PEEP of 8, but they are needing 60%, their PaO2 is maybe 80 and their FiO2 is 60. But how do you know which one is more sicker? You know that the kid on oscillator is much sicker because they're needing more higher mean airway pressures. The PF ratio and SF ratio don't take into account the mean airway pressure, which the OI and OSI do. So they are a better indicator of how sick your lungs are. Does that make sense? I can repeat that again. So for example, you have a patient who is on a conventional ventilator, is on a PEEP of 8, okay, and they have a PaO2 of, so we can probably do a math. If someone can borrow a pen, please. So for example, if they are,
just use a calculator.
Sure. So if they're on, for example, you get an arterial blood gas, and if their PaO2 is 60, and they are on 30% oxygen, so you do 60 divided by 0.3, so your PF ratio is 200. If you take a patient on oscillator who is on a mean airway pressure of a MAP of 30, their PO2 is 100 and they are on 40% oxygen, so their PF ratio is 250. So you might say that, oh, their PF ratio is better on someone who's an oscillator, so they're better than the patient who's on conventional. But it's not true because they're needing a higher mean airway pressure to give you those numbers. So that's the reason PF ratio, SF ratio are inferior to OI and OSI, because they do not take into account the mean airway pressure the patient is on. Does that make sense? And then again, this gives into account, for the cyanotic disease, the chronic lung disease, and LV dysfunction. So we're just going to go into details for each of these and what the criteria are. So what they're saying is age should not be a criteria for definition. So they're saying exclude perinatal lung disease. And wherever it says S or W, that means it was a strong or a weak recommendation. So what they did is the panelists came together, and if they said, if 93% and more agreed on a recommendation, it was strong, and if it was less than that, it was a weak recommendation. So that's how they came up with this. They said hypoxemia and chest X-ray findings have to be within 7 days of insult. So if you have a patient with chronic lung disease, if you have new findings on X-ray that are changing from the baseline, and they're within 7 days of that patient getting RSV or flu, then that would qualify as ARDS, even if the original baseline X-ray is abnormal. Does that make sense? And then they should have ARDS criteria that is not explained by LV dysfunction, so they need to have a normal echo. That was same as Berlin. X-ray, we talked about new infiltrate, and then they said we need 2 future studies to measure the inter-observer variability, which is basically, if you have 10 radiologists who are reading an X-ray, someone will say infiltrate, someone will say normal, so we don't really have it like an automated system. So that's what they're talking about. In the future, we need something like that to eliminate that variability. So we talked about OI instead of PF ratios. So PF ratios are only for someone who is on non-invasive ventilation.
Okay.
Elevation of dead space needs future studies, is what they're saying. So dead space ventilation, as we talked about, higher the dead space, sicker the sicker the patients.
Okay.
In adults, it's been shown to have a good correlation to their outcomes. However, in pediatrics, they've not shown great correlation. So we just need more studies. And they said measures of respiratory compliance, again, should not be used for these patients. And this was an important one that they came up with. is someone who doesn't have an arterial line. If you're using saturations, you need to wean their FiO2 down to keep their saturations between 88 to 97%. So you don't need 100% oxygen sat for them. So 97 is the new 100. So if someone's satting 98 and they're on 40% FiO2, you keep weaning them till their FiO2 comes to the lowest FiO2. You can bring them to up to room air to have their saturations up to 97. Because we know that when you're giving them a lot of oxygen, you're causing more free radical damage and oxygen toxicity. So coming to kids with chronic lung disease and cyanotic heart, I guess we're going to see a lot of these kids with chronic lung disease, our population. So if you have an acute change, you can say they have pediatric ARDS. So that's a change from their baseline X-ray. Or if they are on, for example, if you have a 25-weeker who is on a trach vent and normally is on a PEEP of 8 at home and 40% oxygen, but now needing 60% and a PEEP of 10, that's a change from their baseline vent setting. So that's ARDS. Does that make sense? And that's the reason we always ask, what's your baseline X-ray? What's the baseline setting? So if they're needing 2 liters oxygen at home through nasal cannula, but now they're on high flow, or if they're needing like a CPAP, for example, not a high flow because they have to be positive pressure, but if they're needing CPAP with a change in an X-ray, that would be ARDS. What they're recommending is not to use OI or OSI to stratify pediatric ARDS. They're still wanting to use PF-SF ratios for this particular population. Severity of illness and outcomes, and this is an ongoing study that when I was a fellow, we participated from Buffalo, and that was looking at their markers at onset within 24 hours and thereafter, and looking at how they did. And this was, they found that dead space is related to, in adults related to outcomes, but in kids we need more studies. And they found that tidal volume, PEEP, mean airway pressure, and relation of that to outcomes again needs more studies. And this was an important recommendation where they said multi-system organ failure should be included in future studies. What this means is, for example, when we have an intubated patient, you might see us get a bunch of labs. Like we always get like a CMP, you get coags, because you want to make sure that if they're having lung injury, how are their other organs doing? Like how is their heart doing, how are their kidneys doing, how are their coagulations doing? We get a lactate to see how their cardiovascular function is, how their oxygen delivery is. So you want to make sure, is it just the lung that's getting affected or the other organs are as well? And then looking at clinically relevant outcomes, which we'll come to. Coming to conventional ventilatory support. So again, the classic adult low tidal volume had a weak recommendation. Only 88% agreed on that, 5 per kilo. Again, adjusting tidal volume for compliance had a weak recommendation. Limiting plateau pressure to 28. And this is, so the plateau pressure, a lot of times we'll see us doing is the pressure that the alveoli are seeing. So a lot of places will say limit it to usually less than 30, because if you're giving more than 30, you have more barotrauma. Especially in kids who have stiffer lungs, because they're not going to expand with that high pressure. They're just going to be staying stiffer. You keep giving them more pressure, and they're going to be hurt more.
So is that the same as the peak inspiratory pressure? Is that something different?
So you said so you don't really set the plateau pressure, you set the peak inspiratory pressure,
Yeah.
and the plateau pressure is what the ventilator will tell you
Okay.
what they're getting. And usually, but the plateau pressure, sometimes if you have some bronchospasm, there might be a difference. There's up to a difference of 5 is okay. If you have secretions of bronchospasm, your plateau pressure will be a little lower than your peak pressure. But if you have none of that, yes, those both will be equal, because whatever you're giving is what the alveoli are seeing. But the plateau pressure is always the most important thing. That is what the alveoli are seeing at that level point. High PEEP will always help. Well, it was again a weak recommendation, but it depends again on the patient. But they absolutely recommended using more than 15 of PEEP for kids with severe ARDS. And this again came from a recommendation where a lot of centers are going away from using oscillators. I think again, when I got trained, anyone who was needing a PEEP of more than 12 or needing more than 60% oxygen usually went on to get an oscillator, because you're just giving so much high pressures to a conventional to achieve that much of air expansion. But again, there are a lot of centers which will use a lot of high PEEPs and not put them on oscillator.
How does that high PEEP work on the kids with the chronic lung disease?
I think
It seems like team would be like,
Yeah.
lung
I mean, you're at
is
high risk of
very-
pneumothorax as
it's-
well.
yeah.
But again, that's the same with with the oscillator, because if they're needing a peak of more than 15 on a conventional, they're probably going to need a very
I
high
was gonna say
mean
their
pressure
map's
too.
probably already gonna be at
Exactly,
30.
30 and above. Yeah. So either way, it's
You just
the
think that
same.
would cause more damage to
Yes.
already damaged lungs.
It would, but again, at that point,
Yeah.
you need something to expand them.
No, is the oscillator, because I'm from the adult world, is the oscillator something that it's quick and fast, basically?
Mm-hmm.
Is that what it is? And it's still,
It's a little different. What oscillator does is it gives you low tidal volumes. So
okay.
normally oscillator volumes are like 0.5 to 2 ml per kilo, and correct me if I'm wrong.
You're right on.
And what it does is, in your conventional ventilator, your oxygen and ventilation are coupled. They're together. They're apart, right? So when you increase your PEEP, your oxygenation improves, but you're also opening more alveoli, so you have more ventilation. In oscillator, they're uncoupled. So they're just three knobs. You know, your MAP is your oxygenation with your FiO2, and your amplitude and frequency are your ventilation.
Okay.
So if you have a gas which is 72572, but your PO2 is 80, you don't do anything to your MAP and FiO2. All you do is that your amplitude and your hertz, you adjust those. Does that make sense?
Yeah.
Yeah. And
I've
your
never seen one.
That's okay.
Yeah.
Well,
I mean, I think it's a
We'll
great
get
it's a
you.
great question. It's beyond the scope of today's lecture, but we'll talk in particular about just conventional ventilator, just oscillators in detail, and then we'll go over that. Yeah, but just it's a higher form of event, like it's higher, one step above the conventional. And the reason you have not seen it is, again, because a lot of they're going away from using oscillators in the adult population. We still use it in pediatrics. I mean, it works great for, but you need to have a great choice of patients where you use it. And then we talked about, and this was really an interesting recommendation, that they say that, well, using respiratory compliance doesn't help outcomes, but you still need to monitor those, and you monitor your hemodynamics and monitor your oxygen delivery markers like lactic acid and stuff like that. And then coming to high frequency, so the recommendation to use it, so with patients, as we talked about, if they have continuous plateau pressures more than 29, to use it, it was a weak recommendation. It was only 92%. But everyone agreed that stepwise increase or decrease in mean airway pressure to achieve optimal lung volume is important in response to hemodynamics, which, as you know, if you're giving a lot of mean airway pressure, what happens? You have decreased preload, right? Because you're not getting enough blood returned to the heart. So, so the more pressure you give in your lungs, you have, because you should just imagine how do we breathe? Is it positive pressure or negative pressure? What do you think? It's negative pressure, right? Because you generate pressure which is below the atmospheric level and you suck air in, right? And then when you have negative pressure, that augments your venous return. You get more blood into the lungs during negative pressure. Just the opposite happens in positive pressure, where you're giving a lot of pressure, you're impeding the venous return. And that's the reason a lot of times when we'll say, when you're putting a patient on oscillator, you give them, make sure you have enough volume in them, you have enough epinephrine, because they can arrest by just putting them on oscillator, because you just don't have enough venous return to the heart. And if you're giving them very high positive airway pressures, you can cause arrest because there's just no blood volume in the cardiac cavity. So that needs to be monitored, is what they're saying. And then routine use of jet is not recommended in ARDS. And again, this is from practice across the country. A lot of NICUs use jets, but a lot of PICUs do not. And usually with jets, you need 2 ventilators, and there's a weight cutoff. I mean, beyond 10 or 12 kilos, you can't really use. So that's one of the reasons why we've gone away from using jets.
and usually unless you have like a big leak, okay, it's the only time that you probably would even consider that as a possibility, and if you're under the weight limit, you know. Otherwise, it's
not really that helpful.
effective.
Again, use cuffed endotracheal tubes, and this is always an important thing, and we get a lot of patients from outlying ERs who do not have a cuffed ET. So irrespective of age, even if it's a 2-day-old who has ARDS or a 16-year-old, everyone needs a cuffed ET tube. The only time you can deflate the cuff is if they're on oscillator, and if you're not able to wash out CO2. I know you guys did that with a patient who was on oscillator, where you deflate the cuff, so you're allowing the CO2 to exhale around the tube. But knowing that if you don't have if your cuff is down, you are not going to be able to oxygenate well, because all your air is not going to go in to inflate your alveoli. So they came up with goals as to for mild ARDS would be PEEP less than 10, and you keep goal stats 92 to 97. With that, they did not reach a strong agreement on that. However, everyone said that if you're using saturation of less than 92%, then use oxygen delivery markers. So what this tells us, if you're taking care of a very sick ARDS patient, I would say sats of 88 are okay. And why do we need an oxygen sat of 100? So what does SpO2 tell you? Josh, what do you think? What does a pulse ox of 95% mean to you? What does that tell you?
That they're oxygenating, they're getting oxygen.
Where?
In their lungs, or through their body.
Yeah, so their oxygen, so that's the amount of hemoglobin that's saturated with oxygen, right? So 95% of the hemoglobin is saturated with oxygen, so the number is 95%. So that's the amount of oxygen it's going to give to the tissues. When you are satting 88%, that means only 88% of your hemoglobin is saturated with oxygen. But then, if you're allowing someone to stay at 88 sat for a long time, the question is asked, is that enough to maintain the oxygen delivery for all the tissues? And how do you look at oxygen delivery for a patient?
ABTs. I mean,
Perfusion.
Yeah, so your perfusion, their brain function, so they're just sedated, non-muscle relaxed. You can look at how their neural activities, how the urine output is, so the end organ, your kidney perfusion, your lactic acid, so you're using oxygen, you don't have anaerobic metabolism, so your lactate is less than 0.2. So those are the markers of oxygen delivery. So if those are normal, if you have good urine output, your lactate is normal, your heart is not getting affected, you're not acidotic, then you can say at 88% you're perfusing the body okay. You don't need to go up on your oxygen sats. Because what you're doing is you're giving them more oxygen to go up on your sats and you're causing more lung injury. So you have to have a balance of that. Does that make sense?
Mm-hmm.
So you can tolerate lower sats as long as your oxygen delivery is okay. And then the most important concept is permissive hypercapnia to minimize the ventilator-associated lung injury. And this is where a ventilator-induced lung injury. And this is more where if you get a blood gas, an arterial blood gas of 725 and above, pH is okay. So if you get a gas of 72759, you don't have to go up on the rate or the tidal volume to get a normal pH. Because what they did in the past is they would want to make sure the PCO2 was normal, and in the time they were getting more volumes, and then they were causing more days on the ventilator and causing more lung injury. So they thought as long as your pH is okay, where all your enzymes in the body are functioning at a optimal pH, you don't need to get your PCO2 within normal range. I've tolerated PCO2s in the 70s or 80s. I think when it reaches like 90s or 100s is a point where your CO2 will displace oxygen at the alveoli, because it's 20 times more diffusible than oxygen. But up to 70s or 80s, like low 80s, is fine, as long as your pH is normal. So always look at your pH. Then the only exception to this is someone with traumatic brain injury, because your PCO2 is directly related to cerebral blood flow, so you wouldn't allow your CO2 to be that high. And someone with pulmonary hypertension, because high CO2 will cause increase in pulmonary vascular resistance. So those are the two exceptions. But otherwise, permissive hypercapnia, permissive hypoxia is the way to go for managing
cardiac
ARDS.
lesions, you use that for cardiac lesions as well?
Not for like a cyanotic heart disease, yeah. So again, when they came up with these goals of 7.15 to 7.3, I think that was a weak agreement. I think most of the centers would recommend an arterial pH. As long as you're 7.2 and above, you have decent perfusion. We talked about like in our DKAs, right? I mean, if you're a pH of 7.2 and above, you can give them Lantus, because you know it's going to get absorbed subcutaneously well. Because at 7.2 and above, most of your enzymes are functioning, you have decent organ perfusion, that is tolerated. And routine use of bicarbonate is not recommended. And I think this is very important, because how does bicarbonate get released from our body? No, it won't get
It breaks
through the
down
kidney.
into water and carbon dioxide.
Yeah, absolutely. And how does carbon dioxide get out of our body?
Anhydrous.
From ventilation, right? So if you are controlling,
Carbonic anhydrous.
absolutely. So if you are controlling someone's ventilation, what's going to happen? If someone has a pH of 7.15, 7D, and if you give them bicarbonate, you're causing worsening respiratory acidosis if you don't blow off that CO2. So giving bicarbonate just to make that number look good is not recommended, and it's not helpful, especially if you do not have if you're controlling their ventilation. So that's one of the reasons why bicarbonate has gone away from the code meds, because if you're arrested, you do not have any pulmonary blood flow. And the only way you can get bicarbonate to get to the lungs and outside into the atmosphere is through the pulmonary vessels. And if you don't have any pulmonary blood flow, because you don't really have any blood flow, you're arrested, if you're giving bicarbonate, that's going to worsen your respiratory acidosis and make you much more sicker. And that's why bicarbonate has gone away from a code med, because no one used, that's the reason we routinely don't give bicarbonate in patients. What about inhaled nitric oxide? So routine use is not recommended. So nitric oxide makes the numbers look great, but they looked at long-term, their ventilator-free days, days in PICU, days in hospital, didn't really change. So routine use is not recommended, except if you know they have pulmonary hypertension, if they have RV dysfunction based on echo, or as a bridge to ECMO. So like the patient where, we were thinking about ECMO, you're throwing everything but the kitchen sink, consider nitric oxide, but not in a regular patient.
Did she end up getting an echo? Did you look at her? Did you
My
look
plan
at-
was
she
the
had
next
some
day, but
pulmonary
I wasn't on calls. I mean,
Oh.
so I don't know if she got an echo.
Not that I'm aware of,
Yeah.
not when I was here.
I think I thought they said she did,
Well, she could have, but
Yeah,
yesterday we didn't do it.
not a,
No.
I think that. What about surfactant? Surfactant is not recommended anymore. They found increased risk of pulmonary hemorrhage with surfactant. So again, it's like your last resort. Patient is probably on ECMO or going on ECMO. You want to try something, try surfactant. Prone positioning. So again, not routinely recommended, but they're saying it was a 92% agreement to be used in severe pediatric ARDS. There's more and more studies coming out with prone, and we can, do, it's probably a separate topic for discussion. If you prone someone, it has to be at least 14 to 16 hour proning. So it can be a short term because you need it to show effect. There are a lot of studies which are coming with early versus late proning. So early is within 48 hours of being intubated. The disadvantages of proning are you have to be muscle relaxed. So because you have a risk of your endotracheal tube getting dislodged. So you're predisposing them to more critical care myopathy by keeping them paralyzed. But again, it does have its advantages. Suctioning, again, helpful, but again, you want to make sure that you're not causing re-recruitment, especially if they're on a very high peak. Routine use of saline is not recommended. Again, saline is known to cause alveolar hemorrhage, so because it depletes surfactant with constant washing. We like it, it's going to wash out all the secretions and get them out, but it also washes your surfactant with every time you give it. So it's not good. It's only recommended if you know that the secretions. Chest PT, again, was not routinely recommended for ARDS. A lot of our RTs in Buffalo would love to show me this article, when we had like 18 intubated patients and we would order chest PT on everyone. They're like, hey, chest PT is not recommended routinely, so can we just triage patients who really need it? So again, the way I look at it is you can try one, see how they're doing. I mean, everyone is different. Some might like Medanep, some might like just manual percussion. Every kid is different, so you have to assess and go with that, with what the kid needs. And routine use of steroids is not recommended for ARDS. So sedation and neuromuscular blockade. So the recommendation is minimal and effective target sedation. So whatever, enough to keep them sedated. So not everyone needs to be knocked out. They're recommending use of sedation scales. Again, we were talking about how we should have a formulated sedation scale for pediatrics. Objective withdrawal scoring. So once they're off sedation, you want to monitor the withdrawal. And when sedation alone is not effective, you use neuromuscular blockade. And then again, using 3 or 4 daily paralytic holidays, where you stop the paralytic for a little bit, allow the kid to move, put it back on, is highly recommended. So having a formalized nutrition plan, always prefer enteral nutrition over parenteral. Early enteral nutrition is within 48 hours of hospital admission. So, and not again giving them GOL. Even if you get 5 an hour of trophic feeds into them, is fine. Keep the gut healthy, because if your gut is not getting fed, there's denudation of intestinal mucosa, you have a bacterial translocation and increased risk of infection. So always getting some feeds, at least within the first 48 hours if they're hemodynamically stable, is preferred. Again, having a goal-directed protocol for that is recommended. Again, goal-directed fluid management, so aim to prevent positive fluid management, and we talked more about this, where if the patient is on intubated, they're not having a lot of insensible water losses. So you want to restrict their fluids to begin with rather than chasing them later with diuretics, because they have their own side effects. PRBC transfusion is only for hemoglobin less than 7, or if they are having cyanotic heart disease or hemodynamically unstable, or they're like bleeding, you're like on a PEEP of 12 and you're on 100% oxygen and you still cannot bring up the SATs. Yes, that's probably an indication where even at a hemoglobin of 9, I would say consider transfusion. But otherwise, you would give it 7. Our labs are adult fashion, so anyone less than 9 will trigger a critical, because they're not, peds sensitive. The lab. So sometimes less than 9 will say critical, but you need to understand the patient is on PEEP of 5, 30% oxygen, probably going to get extubated in 2 days. They don't need a PRBC transfusion. So monitoring, as we talked, specific alarms, which we already do, measuring weight, which I think we are so great at. We get daily weights, which we never got in Buffalo, so I think that's huge. I was really pleasantly surprised that we get daily weights in everyone. That's amazing. I think that's great to know, especially if they're gaining weight. It could be from fluid like body water, edema. So knowing that. Use of end-tidal or transcutaneous CO2. So if you're on conventional end-tidal, if you're an oscillator, transcutaneous is helpful. Measuring your inspiratory pressures. Peripheral blood gas sampling, like VBGs, are not recommended. And they say either you get an A-line or you just monitor with like, you can do cap gases. But routine peripheral gases are not recommended. You can do like from a central venous line. Coming to weaning and imaging, so again, use of spontaneous breathing trials, extubation assessment. Again, the day you intubate the patient, you should start thinking about extubation. Like not extubate the next day, but thinking about when this patient will be ready. Routine use of CT, lung ultrasound is not recommended. Again, most patients will get daily x-rays if they're intubated, but if someone's stable, you don't have to get everyday x-ray just for tube placement, especially if the muscle relaxed, they're not moving. So echo, again, for RV or LV dysfunction. Recommending a peripheral outline for severe ARDS, that was a strong recommendation. There was not enough evidence to measure like BNP, that's for cardiac failure, or mixed venous oxygen monitoring, unless you suspected oxygen delivery issues. I just have a couple more slides on NIV. So NIV should be delivered in a setting with trained and experienced staff, and that's the reason most of the patients who need non-invasive ventilation are in the PICU. Again, consider invasive positive pressure if there's no clinical improvement, and high flow should not be considered as equivalent to non-invasive positive pressure, and this was a recommendation that came from them. And again, always use heated humidification. A lot of times I will say if someone's on like 2 or 3 liters, I would still keep them on high flow and not transition them to a nasal cannula just because it's heated humidified. And plus you can titrate their FiO2. So it's easy, especially if they're going to be on 2 or 3 liters for 2 or 3 days. You don't want the nasal mucosa to get dried up. Again, sedation should be used with caution, especially someone on non-invasive, because you don't want them to like have their breathing suppressed. And that's where Precedex, I think, is a great medicine, where it can sedate without causing respiratory depression. Again, ECMO is when all standard measures fail, especially if the respiratory etiology is reversible, and if the patient eventually, if it's going to need a lung transplant, is a suitable candidate, you need to consider. So someone like our patient, the 15-month-old, I think she was a great candidate if she would have needed ECMO. Again, assess quality of life pre-ECMO. So if someone's like MRCP, I would not consider ECMO. Or like for example, our patient who came in with hanging, the 16-year-old, and he probably was ECMO material all night, but we did not put him on. We did not consider ECMO because he had fixed dilated pupils on exam. So neurologic exam is most important, single most like an ECMO checklist indicator for if they're going to need ECMO or not. But someone who was doing great pre-ECMO, I think they should be always given that option. Does anyone know the difference between VV and VA ECMO? Venous, yeah. So and then when would you use VV or VA? So the best is, yeah, sorry, go ahead. No, go ahead.
You would use the VV if there's a cardiac issue, correct? And VA if there is a
other way around. The other way around. Yes.
Okay, that was
Yeah,
close.
but you're close. Yes. So VV is if it's only lung failure, it's VV. If it's lung and heart, it's VA. So for example, if someone has septic shock, is on 2 pressors, not doing well, needs VA. Their lactate is 10, they're hypotensive, you're on like epi of 2, nor-epi of like 0.2, whatever, and then those are patients who need VA. Like for her, she was not on any pressors, doing well. Her only issue was oxygenation ventilation. It was just the lung. It's VV. So VV is just the veins. They'll just put like a right IJ catheter. It's either percutaneous or surgically. And then for VA, it's the IJ and a carotid is what they will do. And then some of the outcomes that they're looking at, and hopefully the study comes out soon, they're looking at 90-day mortality, new or progressive organ dysfunction. So if they already came with a kidney dysfunction, how did it progress, or what was the new they developed with ARDS? Treatment-free, ventilator-free days. If they needed oxygen use for home, or it was a change from baseline for the chronic lung disease. And they're looking at risk-adjusted hospital and PICU length of stay and readmission rates. And then they're actually sending out surveys to patients who went home after ARDS to look at their quality of life, neurocognitive function, and emotional health. So there's a lot of studies that's happening on the neurodevelopmental effects that happen, because you're sedated, you're paralyzed, you're giving all these medications. You don't know how they're going to do later on, like in their tests and or just in life in general. I mean, we don't know. So, and then I think what we'll do is we'll have this laminated. I think Mary Jo, I think that'll be helpful just to know. So what I really would like, I mean, I think for all of us to like use the terms more often. Like, is this patient ARDS? Or if someone's on 15 liters high flow and has a new infiltrate, you can say, I think this patient is at risk of ARDS because they're still not meeting criteria because they're not positive pressure. And once they're on positive pressure, I think we should calculate OI, OSI, and I think that should be something that we should report on rounds every
Exactly.
day. And again, Archie, not to put you on the spot, but something that you guys, I think it's an objective number where we can say, hey, the OI was 12 yesterday, today it's 7. I think we're getting better from that standpoint. And then we can classify ARDS as well from that. I think that's it. Any questions? Thank you for listening.